So now let us look at the cardiometabolic continuum. This cardiometabolic risk is something like a spectrum, starting from the level of risk factors in the cardiometabolic risk here, at which stage it is the prevention that is the key, and we have to attempt and see to reduce the risk factor levels and also to modify the lifestyle and see that these risk factors of cardiometabolic disease will not allow the patient to progress on to the target organ damage. So, this is the first stage or stage of primary prevention, where you require to identify the patients at higher risk of cardiometabolic risk and start treating them. Of course, once the patients pass that particular stage, after some years and sometimes even in some months in very aggressive atherosclerotic patients, they will end up in what is a stage called a secondary stage, wherein the target organ damage will occur. At the same time, the patients are still not symptomatic, some of them, and there could be newer risk factors also that may be there, and atherosclerosis already has started occurring on the blood vessels of all the vasculature, particularly the coronaries, the cerebrals, the peripheral vessels and the renal blood vessels. This is a stage at which we can regress the changes of atherosclerosis and reduce the target organ damage and see that the patient does not become symptomatic and tackle the newer risk factors. In addition to modifying the risk factors of cardiometabolic risk by proper preventive strategies, at the stage of second stage, we have to regress the changes and try and intensify our efforts to see that they do not progress onto a symptomatic stage of target organ damage. The third stage, of course, is when the target organs are affected, like the renal damage, the vascular damage of the eyes, vascular damage to the peripheral blood vessels, cardiac damage, cerebral blood vessel damage, and this is manifest in the form of symptomatic target organ damage. Depending on the target organ that is affected, the symptoms will be there. In this stage, what we can do is only retard the progression of this patient to going into the severe form of the disease and complications and death, and we cannot completely regress the changes that have taken place here. And of course, this is a stage where it is a tertiary prevention stage. So, this is a stage of primary prevention, stage of secondary prevention, and then the stage of tertiary prevention. Once the target organ damage has occurred, let us say once the myocardial infarction has taken place in a patient, we only require to see that he does not get a reinfarct and he does not succumb to the left ventricular failure and left ventricular damage, and then end in sudden cardiac death or progressive cardiovascular morbidity. So, this is how we have to look at the cardiovascular metabolic continuum or cardiometabolic continuum it is called. So, the stage where we can prevent in the first stage, regress in the second stage and retard the progression of the events in the third stage. This slide gives an idea about what will be the cost of the management of events in the various stages. In the first stage, the number of people who will be so many, but the events will be so small, and then the cost for controlling those events or treating them and or preventing the onset of complications and stopping the progression of the disease and tackling the cardiovascular risk factors by proper preventive strategies and lifestyle management will be much cheaper at this stage, though we may have to address this problem on a larger number of patients. Then again, if we come to the second stage, again the number of events in the second stage will be larger compared to the people who are suffering, and of course the cost will be intermediary in the second stage. But once they develop the target organ damage and then the symptomatic stage has come and the symptomatic cardiovascular disease develops, then of course the cost of management of such patients is going to be extremely high. So, around 75% of the events occur in first and second stage, and then 25% only of the events will occur in the third stage. But the cost for the patient's management in the third stage will be enormous compared to the cost of management in the first and the second stage. Keeping this in mind, we always should try to attempt and see that the patients in the first stage are prevented and by primary prevention and not allowed to go on to the second stage, and if they go on to the second stage, then we have to institute measures of secondary prevention and see that they do not develop the third stage disease, wherein the treatment costs are extremely high and the availability of the treatment modalities is also scarce and not available to all the patients. So, this is very important for us to understand. Around 20-25 years back, it was thought that coronary artery disease, cerebrovascular accidents and stroke, chronic kidney disease and peripheral arterial disease are different diseases and they are not interconnected. And today there is a paradigm change in the thinking. All these diseases, may it be CAD or CKD or CVD or PAD, they are all different manifestations of same vascular ill health or same vascular endothelial dysfunction. So, with the result, now the concept of what is called cardiometabolic risk as the underlying thing, as you can see in the background, the cardiometabolic risk, which is the one which culminates in CAD or stroke or PAD or CKD, and obviously all of them overlap each other and overlap one another, and they are all now encircled into one particular disease or syndrome. So, it is now important for us to understand a person who is suffering from one of the manifestations of the cardiometabolic disease like CAD. We must sure look at the other territories like the blood vessels of the lower limbs, the kidneys, the kidney renal function, and of course the cerebral blood vessels. The same thing holds good for other manifestations like PAD, CKD and CVD also. So, when you see a patient with any one of these manifestations, obviously there is vascular ill health, and that is going to be there everywhere in all the vascular circuits. So, we need to thoroughly investigate and see that we prevent the damage of the organs that are not yet become symptomatic. This is very important. Please remember that these two, that is the diabetes and the cardiometabolic risk, they are interconnected. You cannot separate type 2 diabetes from hypertension, CAD and heart failure. If a patient has got hypertension, if the patient has got CAD, or if the patient has already got heart failure, and if he has got diabetes too, one perpetuates the other. Diabetes aggravates the heart failure, hypertension, and CAD heart failure and hypertension aggravate the diabetes. One perpetuates the other. So, diabetes is itself remarked as equivalent of cardiovascular disease or equivalent of a CAD. So, diabetes is a CAD equivalent. So, a person with diabetes, we have to treat him as though he already had an acute CAD event. So, that is the aggressiveness with which we have to treat every diabetic patient. And of course, if they have the comorbidities like hypertension or CAD or heart failure, the problem would be compounded and one perpetuates the other. This slide again is to impress upon you that these are perpetuating one another. You see in the center of this particular circus or cycle, you see the endothelial dysfunction, which is the common underlying denominator for all these disease. Endothelial dysfunction is caused by abnormal lipids, hypertension, diabetes mellitus, chronic kidney disease and CAD. Endothelial dysfunction causes all these things. Each one is responsible for the other, and dyslipidemia aggravates hypertension, diabetes aggravates hypertension, hypertension aggravates diabetes, diabetes and hypertension cause CKD, and all of these aggravate the CAD, and then lipids of course have a negative role on any one of these factors. So, they are very much interconnected. Be it dyslipidemia or diabetes or hypertension or chronic kidney disease or CAD, their underlying problem is endothelial dysfunction, and each one perpetuates the other. Each one is very much interconnected with the other, and each one contributes to the endothelial dysfunction, and each one is affected by more and more endothelial damage and endothelial dysfunction. This is very essential for us to understand. This slide is often, I call it as the Dasavataram of the cardiovascular ill health. Increased cardiovascular risk is due to several factors which we already know that each is interconnected to the other and each perpetuates the other. Let us say starting with dyslipidemia, abnormal lipids, high LDL, low HDL, high triglycerides, high small density lipoprotein, high LPA levels, high non-HDL levels, all of them contribute to increased cardiovascular risk. Hypertension, needless to say, systolic as well as diastolic hypertension. Nowadays it is important to realize that systolic hypertension must be treated, and systolic hypertension is also the main culprit. And then we also should look at the pulse pressure. The wider the pulse pressure, the more is the cardiovascular risk. Then of course, no need to emphasize the fact that visceral obesity, the abdominal obesity, the pressure in the tummy plays a vital role in increasing the CV risk. The obesity now is more quantified on the basis of the abdominal measurement using inch tape. So we have now moved from the stethoscope to the inch tape to diagnose increased cardiovascular risk. So visceral obesity is highly essential to be identified and then treated to decrease the cardiovascular risk. Pro-inflammatory status in the blood, and then pro-thrombotic status, endothelial dysfunction, vascular ill health, and of course impaired glucose tolerance, impaired fasting glucose, the pre-diabetic states, and of course you have the established insulin resistance and diabetes mellitus and hyperinsulinemia to start with, and then there will be beta cell apoptosis and failure. All these cause increased cardiovascular risk. So cardiovascular mortality and cardiovascular morbidity is due to what is called the cardiometabolic risk. The cardiometabolic risk, as we have seen, manifests in the form of several diseases, and here there are several mechanisms are listed for those underlying diseases in this particular slide. Let us now look at the chain of events in CAD. Coronary artery disease is the center point. The starting point is cardiometabolic risk. Increased cardiometabolic risk predisposes to left ventricular hypertrophy. Left ventricular hypertrophy slowly throws more and more strain on the myocardium and results in coronary arterial disease. The coronary arterial disease, then it will lead to that is ischemic heart disease. This coronary arterial narrowing leads to ischemic heart disease, and that could be a silent one, or it could be an angina, recurrent angina, crescendo angina, unstable angina, and then probably may go in for the next stage, or the myocardial hibernation may occur. Myocardium is not getting enough blood. Part of the myocardium, though is not symptomatically producing the patient to have angina, it might still be having a hibernation of the myocardium may be taking place, and this IHT will now go on, may go on to the acute coronary syndrome stage, where you have got unstable angina and then the ST segment elevation myocardial infarction and the non-ST segment elevation myocardial infarction, and this is acute coronary syndrome, and the AMI acute myocardial infarction is the ST segment elevation myocardial infarction or the QA myocardial infarction. Then you have got left ventricular remodeling. Left ventricular remodeling occurs, and once the left ventricular remodeling occurs, that will pave way for arrhythmias and sudden cardiac death. Then you have got HMR, that is heart muscle totally remodeled, and then the hypertrophy, sometimes aneurysms, sometimes dyskinesias, sometimes akinesias, sometimes you may have dilatation, and this is what is called heart muscle remodeling, and that results in congestive heart failure, systolic heart failure, and sometimes the ejection fraction may be normal and still you have heart failure, that is called the diastolic heart failure. And of course the end stage heart disease or EHD is the cardiac invalid. The patient will not die, nor he will be living comfortably, and such status is much worse. So we have got CMR cardiometabolic risk state, left ventricular hypertrophy, coronary arterial atherosclerosis, ischemic heart disease, angina, silent patient, hibernation, acute coronary syndromes, non-ST segment elevation and the unstable angina, then ST segment elevation, myocardial infarction, left ventricular function deterioration causing arrhythmias and sudden cardiac death, and then left ventricular muscle remodeling occurring, and then of course ending in heart failure, either systolic or diastolic, and then the end stage heart disease. So, what do we want to do? We do not want any patient to end up here, neither here nor here. We want him to catch here and see that he does not progress down the chain, and maybe arrest at that level, if not possible at least at this level, and see that people will not progress beyond this level. Unfortunately, not all patients go through the chain here. Some may go directly from the CMR to acute myocardial infarction without there being the transitory stage. Such patients are at a greater risk because they are not given the warning time or the lead time to do any intervention or to follow any lifestyle modification, and suddenly overnight they get up in the morning and then develop acute myocardial infarction. This is due to the vulnerability of the plaque and the sudden atherothrombosis of the coronary arteries due to rupture of a vulnerable plaque, and that group is the one which is very difficult to predict and then treat also.